The broadcast is now starting. All attendees are in listen-only mode.
Here's a little song I wrote. You might want to sing it note for note. Don't worry, be happy. In every life we have some trouble, but when you worry you make it double. Don't worry, be happy. Don't worry, be happy now. Don't worry, be happy. Don't worry, be happy. Don't worry, be happy. Don't worry, be happy. Ain't got no place to lay your head. Somebody came and took your bed. Don't worry, be happy. The landlord say your rent is late. He may have to litigate. Don't worry, be happy. Look at me, I'm happy. Don't worry, be happy. I give you my phone number. When you worry, call me and make you happy. Don't worry, be happy. Ain't got no cash, ain't got no style, ain't got no gal to make you smile. But don't worry, be happy. Cause when you worry your face will frown, and that will bring everybody down. So don't worry, be happy. Don't worry, be happy now. Don't worry, be happy. Don't worry, be happy. Don't worry, be happy. Don't worry, be happy. Don't worry, don't do it. Be happy. Put a smile on your face. Don't bring everybody down like this. Don't worry. It will soon pass, whatever it is. Don't worry, be happy. I'm not worried. I'm happy.
Good morning, everybody. I hope you can hear, and I hope you can see me, even though it might be a little bit shocking. Today is Tuesday. I believe it is the 19th of October. It's 9 o'clock in the morning here in the Chicago area, Central Daylight Time. And this is webinar number 5. We've done 4 of them already, so we're off to a good start. In fact, we're about halfway through general pathology. And I know what you're thinking already. If you've had attended any of the previous ones, you might be saying right now, oh, when does the real stuff start? You know, we're getting all this histology and cell biology and, when are we going to have real stuff? Well, the real stuff starts Thursday. However, today we are going to have our final discussion on things that you might call basic science or cell biology. And that will be the personality of what we'll talk about today. It'll be called healing or regeneration and healing, okay? So I guess we could probably start on it right now. I feel that everybody can hear me and see me well. It would be nice if somebody just commented, we can hear you, we can see the screen. That would be nice because I think everything is working good. All my buttons look like they're properly pressed. My microphone is working, everything is recording. And thank you for making the comments. I appreciate it. Let's close down the ugly guy and get into the real pathology stuff. So here we go. Regeneration and healing. Actually, we'll be saying very, very little on regeneration. So we're going to be talking mostly about healing. Now, you know, we spent a lot of time, in fact, an entire webinar talking about inflammation and all the consequences of it. Of course, we really did not get too much into one of the things that is highly associated with the sequence of all the changes in inflammation, and those are the sequence of all the changes in healing. And that's what we're going to do. I guess another name for it might be repair, okay? So what we're going to do today is a few things. We're going to talk about the normal physiology and histology and concepts of cell proliferation, cell growth, cell cycle. I know this sounds like a basic science lecture and not really medicine, but it's crucial to understanding of disease processes. The big word that we're going to try to understand, and nobody could ever really understand it enough, is this word of differentiation. How one cell can multiply and then become something that is a little bit different. It may have lost some of its abilities, but it may have gained some new specialized abilities. And this is something pathologists think about all the time, every day, especially when we talk about differentiation of tumors. You know, one of the 3 big diseases, tumors. Okay, we're going to talk a little bit about regeneration. It's not so much associated with trauma or inflammation. It's regeneration. When I think of regeneration, I think of a frog or something like that, or a tadpole, you know, that lost its tail and all of a sudden it grows back. Well, you know, that doesn't happen in humans, but there are certain types of regeneration in a limited fashion that are highly associated with healing, okay? We all have been talking about cells. But today we're going to talk about the stuff between the cells, or what we call the extracellular matrix, playing an incredibly important role in all of these things we talked about, like cell proliferation, cell growth, cell cycle, cell differentiation. And finally, the one thing that we have kind of neglected so far is when we talked about inflammation, we said, well, things can return to normal, or things can be scarred, or things can still be inflamed chronically. But we didn't talk about this concept of angiogenesis or granulation or neovascularization. It's basically all the same word. And how, under the influence of these mysterious but wonderful things called growth factors, or GFs, we have a system now, just like we had the system with inflammation, a sequence of rather linear events now in the process of healing, okay? And just like we said, there's basic three processes to inflammation. You know, we said there's the vascular phase, there's the cellular phase, and there are the cellular mediators. Well, pretty much the same thing goes on now with healing. Okay, we have a new vascular phase, which is the ingrowth of new blood vessels. The primary cell here is the endothelial cell. And then we have a wide population of other cells involved in the healing or resolving inflammatory or damaged area. And they, of course, will be eliciting a wide variety. We're going to go into a laundry list of about, maybe 10 or 15 different growth factors. Things that might seem like a little bit boring to you, but you know, there's really never enough that we can really find out about them. Growth factors are these tiny little things nobody knows about, but they are basically these little protein molecules that are directing the whole new sequence or saga of events, just like the mediators directed the inflammatory saga. We have the growth factors directing the healing saga. And finally, the endpoint. One of the things we said about inflammation, that could end in fibrosis. And of course, scarring, okay? Fibroblasts making collagen, a scar, the scar becoming stronger, a two-phase event. But we're going to be talking about the final end stage now of both healing and what we also mentioned in the inflammatory events. And the healing can have a little bit of fibrosis or no fibrosis or a lot of fibrosis. And that depends entirely on the amount of damage of the extracellular matrix. And that's going to be basically the thing that determines what we call first from second intention healing, with first intention healing being like a surgical scar. You make a clean incision, the edges are lined up again, boom, no fibrosis. You know, those are the good surgeons, the ones that don't leave scars, okay? Then there's second intention healing, usually often not due to a gifted surgeon, but perhaps a traumatic event like a car accident or a cut or a bad scrape or something, in which the edges are not lined up cleanly and there has been an extensive amount of damage to the extracellular matrix, and now we may have a big scar. Okay, so let's do the definitions in general. Regeneration is growth of cells to replace lost tissues. It does not necessarily mean lost due to injury, okay? It could just simply be a normal substance, not process, not present so much in humans, but in lower animals, especially the lower invertebrates, where they can grow back like an entire limb. In humans, there's a limited amount of regeneration, and it may not even be like a true regeneration, or it may be something like a compensation that we'll talk about later. And of course, healing is what we'll be talking about. Healing is now a reparative process. It responds to injury, necrosis, inflammation, and it's the other half or the continuation of what we talked about last Thursday. Healing generally has as its first major event something called granulation tissue, occurring quickly, perhaps even a couple of days after the inflammatory event, and certainly overlapping with it too, okay? A granulation tissue, another name for that is organizing inflammation. Another name for that sounds a little more high class, is neovascularization. And of course, if you've been up making rounds yet in the hospitals, a lot of times the residents will just call it ticking. Ticking. I don't know where that term came from, but it all refers to the fact that after an inflammatory or damaging process, one of the primary things that follow it is the ingrowth of new blood vessels. And that's what all these three things refer to, okay? Now, regeneration, on the other hand, is simply replacement of lost structures and the normal turnover. Now, the type of cells in your body that turn over normally fast, that they regenerate fast. You know, like bone marrow cells, or perhaps crypts in your GI system. The types of cells that don't hardly turn over at all, you know, like muscle cells, mature neurons, for example, these things will not regenerate at all. Now, there's a certain type of regeneration. I guess you could call it a type of regeneration. It's not entirely different. There's something called compensatory growth. For example, commonly, you may do a CT scan or a nuclear scan of a liver on somebody who's had a previous, let's say, partial hepatectomy, okay, maybe for a tumor. Well, as time goes on, even if the patient lost half their liver because of the surgery, you'll see slow enlargement going on. And that may also be true with things like kidneys, too. Somebody loses one kidney, the other one might get a little bit bigger. Okay, that's compensatory growth. It's not really a true regeneration. So we'll be talking about healing, or we also called it repair. Well, in order for something to heal, there has to be some damage that was done, or an inflammatory process, or necrosis, or a wound, for example. And even though we kind of think of it as the follow-up to the inflammatory diseases, let's say, it also is present in all the diseases. You can get healing changes inside of a degenerative disease. For example, a blood clot, or atherosclerotic plaque, or a thrombosis. You know, that's pretty degenerative, okay? But you could actually see the healing changes. You know, the endothelial cell ingrowth, the neovascularization, the fibrosis even. So healing as a reparative process is kind of present in all types of diseases, okay? You can have a tumor that becomes necrotic. Either it just outgrows its blood supply, or maybe it's radiated, for example. Well, that necrotic tissue will then heal and follow the same type of process that we can be talking about, or we will be talking about, with the so-called nonspecific inflammatory process. Okay, healing often ends with a scar. That's fibrosis. And if you remember the other day, we said one of the three possible outcomes of regular old inflammation was fibrosis, okay? We also said that complete resolution to normal tissue, or no fibrosis, was another possible outcome. And let's see, we talked about a third one. We talked about a persistence of inflammation if the inflammatory process continued or was not completely resolved, okay? Now, when tissues heal, we're basically talking about cells, aren't we? But those cells live in a big house, or a big neighborhood area called extracellular matrix. So, you know, when you build a house, you don't just put boards together, but you have to have the whole environment of where you're working in. And that's what you might call the extracellular matrix. Now, if there has been relatively little damage to the extracellular matrix, or ECM, then there will be just a minimal or perhaps no fibrosis, and you'll have complete resolution. If, on the other hand, there's been a lot of damage to the house or the environment where healing is occurring, then there may be a lot of fibrosis, okay? The more disruption of the extracellular matrix, the more ingrowth of not only blood vessels, but also of fibroblasts. And what do fibroblasts do? Well, they make collagen, and that's the scar, okay? Okay, back to cellular biology 101. This is really a very logical concept here. You know that your body and your organs are composed of cells. You see all these cells? Okay, so you got, so many trillions of cells in your body now. Well, what do they do? Well, we learned that eventually they die, or most of them do anyway. There are certain cells like neurons and perhaps striated cardiac muscle that are not supposed to die. They're supposed to live as long as you do. The ones you're born with are the ones you die with. But basically those cells, most of the rest of the cells eventually die normally, not pathologically, or they could just multiply or proliferate. Or, this is the most important concept, they could proliferate, but when they proliferate, they change. And this is the mysterious, awesome concept of differentiation. Here we have cells that simply multiply. These guys are totally identical to these guys, okay? But if they differentiate, they multiply, and in the process of multiplying, they lose some of their potential properties, but they also gain a specific thing that they may have had here or may not have had here at all. They now have a specialized function. And basically, this is the difference between a fertilized ovum and a total human being, is this concept of differentiation. It's also, in pathology, in medicine, used in concepts of tumors. When a tumor, whether it's benign or malignant, looks and behaves like the normal cells from which they arose, that's called highly differentiated or well differentiated. When they change so much, they differentiate in such a bizarre way, they don't look or behave or function at all like the cells from which they arose, then that's poorly differentiated or undifferentiated. Let's see, there's another really good word for that, and I'll think of it in about a second, okay? Now, of course, all the cells in your body, the ones that are going to divide, the ones that are going to differentiate, or the ones that are going to die, are ultimately derived from a lower, more potential, omnipotential, totipotential, from a less differentiated type of cell called a stem cell. And theoretically, certain stem cells, like a fertilized ovum, for example, can give rise to every cell in your body. It does. Or in most cases, when we talk about stem cells, we're not talking about omni or totipotential. We're talking about cells that can give rise to a whole population of cells, but not every type of cell. For example, the basal cells in your skin, they ultimately can differentiate and divide and proliferate into being all of the epithelial cells of your skin, but they can't form retinal cells, can they? Okay, so much for the concepts of what cells do theoretically. They proliferate. Now, when they proliferate and when they differentiate, they don't just do it for no reason. They're doing it under the direction of hormones, small protein molecules like growth factors, EPO, for red blood cells, CSF for white blood cells, a whole wide variety of growth factors, cytokines, chemokines. Okay, these are going to be the things that we're going to be rattling off in a few minutes, okay? And of course, when they differentiate, I'll mention this again. I said it, maybe I could say it better now. When a cell differentiates, it doesn't just multiply to become an exact clone of itself. When it multiplies, it may gain a certain function. that it didn't have before, but it may lose certain functions too. Why? Because it doesn't need those functions, okay? And of course, we all know, like all people and all trees and all frogs, the cells have to die, okay? And apoptosis is the whole sequence that we went through in the last webinar, so I'm not going to go into it again. Now let's see, I have a little note down here. Did I want to say anything about it? No, I've already went into that. This concept of differentiation is something that we understand more and more and more, and why certain cells become other cells that are more specialized but less differentiated, okay? This is something that we'll probably never really know enough about. Okay, remember these three guys? Of course you do, because you took embryology last year and you remembered we have ectoderm, mesoderm, endoderm. Okay, well, those are the three primary embryologic germ cell layers. Now, everything pretty much before that are omnipotential cells. A fertilized ovum, a blastocyst, those cells can pretty much differentiate into just about anything. But when you have your first primary differentiations of groups of cells, ectoderm, ultimately forming epithelial cells in the skin, a lot of the glial cells, mesoderm, the group of cells that gives rise to connective tissue, or what we might call stroma, okay, and then endoderm, forming a lot of the epithelial cells of the GI tract. Now, ectoderm and endoderm can also form some connective tissue cells, but the primary stroma or connective tissue, you know, bone, muscle, blood vessels, blah, 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 is basically from mesoderm. So just remember those three concepts, because we're going to come back to them pretty soon. I'm sure you remember this guy because you learned about this probably in 7th grade. We learned about mitosis. We learned about cells which divide. And you remember there was a prophase where the chromatin got thicker and they kind of lined up in a line called metaphase. And then they started to separate, called anaphase. And then telophase preceded the actual cell division where the chromosomes are pulling away. Well, that's just a very, very small part of the cell cycle, because after they divide, those new cells are, you know, like a baby in a nursery. They're relatively quiet or quiescent. They don't do very much. They just kind of sit there and grow. And then at some point in time, they decide they're going to concentrate on making DNA, or what they call the synthetic phase, in which their primary function is to make DNA. So the growth phase, or G1, can also be called the pre-synthetic phase. And then after the synthetic phase and all their DNA is made, they even start thinking again about multiplying. So this could be called the pre-mitotic phase, G2, or it could be called the post-synthetic phase. But basically, this is the entire life cycle of a cell. It's born, it grows, makes DNA, gets ready to divide, and it divides. Okay, just kind of remember this. And there is a wide variety of substances which control these processes, and some are longer than others. For example, tumor cells often can be measured by or as an S phase. And the longer the S phase is, you know, the more they're making that DNA. It's generally related to the worse the tumor cells can be expected to behave. So in some of the pathology studies, they may talk about S phases. Okay, so G0, quiet phase. Just got born, split off from the other guy. Then it, after a period in time, becomes pre-synthetic, but cell growth, like in G0, is still taking place. And then in the S phase, we have continuous turnover, production of DNA. And like I said before, the longer that S phase is, the more aggressive, let's say, and at least in tumor cells, you might expect it to be. And then after the synthetic phase, there's another post-synthetic phase, or what you could also call pre-mitotic, because then all the things are getting ready again at some point in time. When it comes time for that cell, under a whole bunch of signals, undergoes your mitosis, and there you are. Those are your regular stages of mitosis, then the ones you always knew about since third grade: prophase, metaphase, anaphase, telophase. And finally, the term cytokinesis refers to the actual splitting up of the two new cells. Another thing that you probably knew about, or maybe you didn't think about it very much, we talk about different cell types and what they do, but you could think of it in terms of lifespan, okay? Now, you know that there are certain cells in your body, like neutrophils, maybe some other white blood cells, maybe the cells in your GI crypts, for example. They only live for a couple days. Those are very labile cells. They have a high turnover rate, okay? Then you have cells which eventually multiply. They don't live forever. The parenchymal cells of your liver, okay, the hepatocytes, renal tubular cells, they eventually will apoptose and be replaced, but they have a much longer life than the labile cells. And then now theoretically, if you looked at a mature neuron or a mature striated muscle, whether it's skeletal muscle or cardiac muscle, guess what? It doesn't have a spindle apparatus. Remember, the spindle apparatus is the organelles or substances which allow that cell to multiply. Now, that's why they say the neurons you're born with are the neurons you die with. Mature neurons, anyway. The precursors to the neurons can technically multiply, and when they do, it may be a brain tumor, for example. But mature neurons do not multiply. Mature striated, either skeletal or a cardiac muscle, is not supposed to multiply either. So if you have a tumor of striated muscle or cardiac muscle, which is pretty rare, they are not from the mature cells. They are from the mature cell precursors. Now, all this talk about stem cells now. We talked about them already. We said basically stem cells can be omnipotential, like a fertilized ovum, or totipotential, which is almost like omnipotential. And there's basically, even though the word stem cells is used kind of loosely, you can talk about embryonic stem cells, especially the earlier the embryo is, the more toti or omnipotential they could be, okay? And then you can talk about adult stem cells, cells in your bone marrow, cells in your epithelial basement membranes that give rise to more differentiated cells rising above that basement membrane. So let's talk a little bit about stem cells now. There's a lot of talk about it, and I want to tell you something. What I'm going to tell you about stem cells is something that's been known for a long, long time, even when I was a medical student. And we always said that eventually, if for many diseases, if you give patients stem cells, it'll grow in new cells and a patient will be well again. You could replace the diseased cells. Well, that's true, and it's being done to a limited degree now. And I'm not going to look at the answer box for the question I'm about to ask you, but I am very curious because I ask this question every year. And I say, how many of you know people whose diseases have been cured by the administration of stem cells, loosely speaking, to replace the organs? I personally haven't met one yet, but we read about all kinds of stem cell therapies for, bone diseases and degenerative diseases and other diseases in which cells are lost or destroyed. Okay. The embryonic stem cell is something that is omnipotential. It has the ability to ultimately develop into any possible cell type in your body. And so at the highest degree of differentiation. Some example stem cells are what they, something done in research very often is work with so-called knockout mice. Okay, that's when they knock out a portion of the patient, of the animals, this is a research item, a genome, perhaps part of a chromosome, and then they see how that affects the person, what kind of disease might it produce or what kind of defect. These are usually cells that are embryonic type stem cells. Now also remember, in embryonic stem cells may be possible to populate a damaged area, and that's being done in certain areas, which I'm not very familiar with, but I heard it's become more and more popular. Just like when I was a medical student, they said it's becoming more and more popular. Well, I think we still have a long way to go. The adult stem cells are not toti or omnipotential. You might call them pluripotential because they have a pretty wide possibility for differentiation, but not like a fertilized ovum, for example. Here's a bone marrow. Looks like a bone marrow. It has a bunch of different cells, the darker cells, the red precursors, the bigger cells, the white precursors, has fat, blah, blah, blah. But about 1% of the cells, and they might be very, very hard to identify easily because they have no differentiation, they have no granules, they don't have any spectacular color differences, would be a cell that we called the marrow hemocytoblast. That term is not used too much anymore, but they're generally referred to as hematopoietic stem cells. In other words, those stem cells have a big ability to differentiate into any of the three types of cells you see in the bone marrow: the reds, the whites, and the platelets. Populating the bone marrow with these cells in certain diseases, particularly leukemias and aplastic anemias, might be life-saving. This is an adult stem cell, happened to be out in the peripheral smear now. There are ways of harvesting these cells from peripheral blood, even though they don't occur nearly as much as you would have in the bone marrow, or they could be just taken and harvested directly from the bone marrow. Well, there's not much of a cytoplasmic differentiation. There's no granules. There's nothing spectacular about the nucleus. Why? Because they're basically stem cells. But even in places like hair follicles or the corneal limbus, for example, you have cells that are differentiating and coming out. And these are technically from much, much less differentiated cells, what you might call a non-marrow stem cell. Let's see, what might be another example of that? Probably the basal cells in your skin. I never really heard to them as being referred to as stem cells, but of course they have a wide range of differentiation possibilities because ultimately they give rise to all the different types of keratinocytes or epidermal cells in your skin. Now, I like this chart a lot. It might look complicated at first, but let's talk about some of the cells you might expect to find in the marrow. You might call this a stem cell. It's not omnipotent, but it's pluripotent, which means it could ultimately differentiate under the influence of various substances. We'll call them growth factors, but there are other types of things besides the classical growth factors. So this pluripotential marrow cell, well, you remember the marrow has fat? Well, it could give rise into an adipose cell. Do you remember a marrow has bone? Well, it could give rise to bone cells or osteoblasts, osteoclast and osteoblasts. Do you remember that it might be near an area where there's cartilage? You could have bone marrow coming right up to an articular cartilage. Well, it gives rise to cartilage cells. It could give rise to blood vessels under the influence of growth factor, vascular endothelial growth factor, the most widely studied growth factor, acts on these less differentiated cells to become endothelial cells, the primary blood cells of blood vessels. Also, there's a wide variety of other growth factors. In fact, many of them have an effect on the ingrowth of endothelial cells. Remember, that's the organizing phase. Okay, that's the granulation tissue. That's the neovascularization, in which you have less differentiated cells under the influence of growth factor. Here's another one, fibroblast growth factor 2, turning these undifferentiated pluripotential cells ultimately into mature blood vessel cells. Here's another one where it's actually becoming a muscular type of cell. So this is basically what we're going to get into shortly, and it's probably going to bore the hell out of you, but I try to decaffeinate it more and more every year. We're going to go through the growth factors. And and there's so many of them, and they all do so many different things, and they all have certain names, and most of the names are misleading. But we're going to go over the influence now when we talk about healing of these various growth factors on less differentiated cells. They come from one type of cell, they may go to another type of cell, or they may go to itself to become differentiated. That key word again. Okay? Now remember we talked about the primary germ cell layers, the first type of major differentiation in the embryo. Here we have something beyond the blastocyst stage, and it has these cells, groups of cells. One of them is called endoderm. One of them is called mesoderm. One of them is called ectoderm. Okay, and the endoderm, if you remember, differentiate into lungs and GI tract epithelial cells primarily. The mesoderm is easy because it's just about every type of connective tissue cell you could imagine, including endothelial cells. And then we have ectoderm. We talked about ectoderm as being primarily skin and some of the different cells of the glia in the central nervous system. So if you've ever wondered how this little ball, ultimately resulting from a fertilized ovum, can then differentiate into these three things, and then these three things can differentiate into every possible type of cell you have in your body, these are all controlled processes. They are processes which have a very high degree of control from various growth factors and other things, which we're going to rattle off pretty soon. But here's how we're going to start off before we take our break. We're going to talk about growth factors in general. There's a zillion of them. They do different things. They have different names. And I said most of the names are confusing. But what do they have in common? Well, they're not carbohydrates. They're not fats. They're polypeptides, small protein chains, basically. You might also say that because they are secreted by cells as protein substances to control other cells, you might call them cytokines. And what are the things that they do to control cells? Well, they might control whether that cell has locomotion or contractile properties. They also direct this major operation called angiogenesis. Remember, we also call that neovascularization or granulation. I don't know what your favorite word is, but the most common word in the literature is, I don't know. The most common word used by clinicians is probably granulation tissue. And angiogenesis, no matter what you call it or term it, is the ingrowth of new blood vessels by endothelial cells under the influence of a wide variety of growth factors. And of course, VEGF, or vascular endothelial, is the main one. But just about every growth factor, or half of them that we're going to be rattling off, probably have some effect on blood vessels. Let's say one more thing about them before we go into them. These are the ones we're going to talk about. And they look like they have very easy names. For example, you might think that the hepatocyte growth factor just does hepatocytes, or you might think that the epidermal only does epidermis. But the more these things have been studied, the more that we see they do a lot of other things other than what their name might lead you to believe. So platelet derived, you think, well, it must come from platelets. Yeah, but it also comes from other cells too, and so on and so forth. So I don't know. I think it would be almost impossible to memorize these. But when we come back after our 3-song break, I'm going to try to tell you the main thing to remember about each one. And we might as well just show you an example, a nice graphic example of what they look like. There's your polypeptide chains, dozens, maybe hundreds of amino acids long. They could be also called, like the cytokines, small protein molecules, or chemokines, small protein molecules, all secreted by the cells. And the cells that they come from may be the same cells that they have their influence on. And that's called autocrine. It acts on itself. But most of the growth factors are made by one type of cell, and they have an effect on a cell which is physically nearby in the injured area. It doesn't go halfway down the body, down the blood vessel, and work on another cell there. That would be an endocrine type of function. So the type of function where a growth factor is made or have its influence on these cells, all of which you recognize as being part of the immune or inflammatory / healing process, are what we call paracrine function. They're made by one cell, and even though they may act on itself, they're probably more likely to act on a neighbor. Okay, I told you I'm going to quit before we get into them, and that's going to be our first one. So let's take a nice little break, and we'll see you in about 10 minutes.
of the evening crawl across the hills. Yeah, walk across the floor with your flower in your hand, trying to tell me no one understands. Trading your hours for a handful of dimes. Gonna make it, baby, in our prime. Together one more time.
Get together one more time. Get together one more time. Together one more time.
Get together one more time. Get together one more time. Get together one more time. Get together one more time. Get come on, honey. Don't hold and wait for me, baby. I'll be there in just a little while. Listen, I gotta go out in this car with these people.
Who can say where the road goes, where the day flows, only time? And who can say if your love grows as your heart shows, only time? We
Okay, those were the three songs that I threatened to throw at you. One of them was one of my favorite groups, The Doors. That's probably popular before you were born, but I really, really love them. And at the very end of the webinar today, we're going to do a song that was given to us by one of our students, and it's a tribute to somebody named Woofy, who some of you may have remembered if you've been to some of the previous 8 years of webinars. Woofy was my dog that was the star of the show, and he's not with us, so we're going to do a little tribute song to him at the end of the webinar, a closing song. Okay, it looks like we're still working here, so let's continue with where we left off. And where we left off was a little discussion, or perhaps enumeration, of all the various important growth factors. Now, I'm not going to put little arrows where everyone is supposed to go, because there's so many things that they do. So what I thought I would do is just divide them into about 8 or 10 different groups, or names, some of which were old names. And the reason why they're misleading is because when they were originally thought to act on one type of cell, they were then discovered later on to act on different other types of cells, but they still kept their same name. So, whereby you might think that epidermal growth factor is for epidermal cells, which of course they are. They're made in platelets and in macrophages. They're in a lot of the body secretions like saliva, milk, urine, plasma. Okay, but they also act on fibroblasts. when fibroblasts enter the picture of neovascularization or granulation. So, does epidermal growth factor affect epidermal cells? Yes, but it also affects fibroblasts, which of course are connective tissue cells. Here's transforming growth factor. And of course, you know, first they discovered an alpha, then they discovered a beta. So now you would have to know that transforming growth factor alpha is a lot like EGF or epidermal growth factor, or the first one that we discussed. But it also has some effect on liver cells or hepatocytes as well. So is that what you want to remember about growth factor, transforming growth factor alpha? Yeah, and you know we're going to mention a beta at one point in time. And of course, if we said there's a hepatocyte growth factor, you would think, oh, well, you know, it probably regulates the differentiation of hepatocytes. Yes, it does, but also endothelium and epithelium. And it's made in connective tissue cells, or what we might call stromal cells, or mesoderm-derived cells. And one of the main effects that hepatocyte growth factor has is on cell motility. Okay, that's what you might want to remember about it, rather than remembering on these complicated pathophysiology diagrams where the growth factors go to. These are their general functions. And some of them may even just be discovered to have new functions by the end of this lecture. Who knows? Now, probably the single most important and most discussed growth factor, and I don't know, I hate to call it important, but it's VEGF. So whenever you hear somebody talk about a growth factor, they'll probably be talking about VEGF. And it has a good name because it acts on vascular endothelium. And the really cool thing about it is, even though it's made in a wide variety of connective tissue cells, it is triggered by hypoxia. Isn't that interesting? Because if tissue was not hypoxic, it might not need additional blood vessels, okay? So you might call this the main growth factor of granulation tissue or neovascularization. It also increases the blood vessels' permeability. And because it's differentiating the endothelial cells, it's also dividing them, making them grow and proliferate. And I would say, if you want to just talk about the main substance, the main growth factor involved in granulation tissue, this would be it. But there's a whole bunch of other ones too. Platelet-derived growth factor is a lot like VEGF, but it also is involved in angiogenesis. Okay, it also divides fibroblasts. Okay, and it's another key player like VEGF in granulation tissue. Now here's fibroblast growth factor. You would think, well, that must have something to do with fibroblasts. Well, it does, but the more it was studied, the more it realized it also involves not only the fibroblasts or connective tissue cells, but also epithelial cells. Generally speaking, the epithelial cells of the skin, or the keratinocytes. It's very highly important in the re-epithelialization when tissue is damaged, perhaps skin, and has an ulcer because of the damage. Well, you know, eventually those epithelial cells have to cover that ulcer again, and this is one of the main guys helping with that process. It's also important in not only the fibrotic phase of fibrosis, but the wound contraction phase as well. You don't just get a scar, but the scar gets stronger, and that's what FGF does. It's also important in hematopoiesis. You see what I mean? Even though it has one name, the more it's studied, the more you realize that it has functions in many, many, many other places. Even striated muscle. So this has a big factor in muscle, in bone marrow, in blood vessels, in epithelial cells, and in fibroblasts. It's made by a whole wide variety of cells too, so that pretty much covers everything, doesn't it? Now remember we talked about transforming growth factor alpha. Whoops. Hold on. Let's see if we could find it again. That we said it was a lot like epithelial growth factor. Well, there's also a beta. And this one actually has kind of an inhibitory role. Like a lot of the growth factors it's made, it's also chemotactic for polys or neutrophils, or you might call it a chemokine, therefore. But it inhibits the epithelial cells, whereas we saw that FGF proliferates epithelial cells. It's fibrogenic, and in the process of causing a fibrosis, you could say directly or indirectly, it's anti-inflammatory. So don't think that all the growth factors are just involved with the proliferation of cells. This is a good example of one that has a lot of inhibitory roles. Well, you're going to figure this one out pretty quick just by the name. There's no confusion here. Keratinocyte growth factor stimulates keratinocytes, helps them divide, helps them proliferate, and helps them differentiate. If you remember, you have these relatively undifferentiated basal cells ultimately going into the stratum granulosum, the stratum corneum, the stratum, germinative, all these different layers of the skin which you hated to learn about can be under the influence one way or another of KGF. And isn't that interesting, is that although it works on epithelial cells, it's made by fibroblasts. So you might remember from embryology that a lot of times the stroma or connective tissue induces or proliferates, or I think the word was induction, whereby connective tissue in the process of cell organization, substances in the connective tissue regulate the cells in the overlying epithelial tissue, and that's like a really good example. You might also remember that insulin itself, the hormone insulin, by virtue of its action with, putting that sugar into cells, is a growth factor, okay? Well, there's an insulin-like growth factor 1, and it's made by probably the number one type of cell that makes most of the growth factors, which are the macrophages, but also in fibroblasts. And it stimulates all of these different compounds like proteoglycans, collagen, keratin, fibroblasts to proliferate. It has a growth-like function. And if you wanted to remember one thing about insulin-like growth factor 1, it has an action that's very, very similar because of its growth functions to the regular old pituitary growth hormone. Okay. Now, you're probably thinking we're near the end of the list, so this one might not be the most important. I got news for you. Tumor necrosis factor alpha, or TNF alpha, is probably the most important growth factor and probably the oldest known. It was noted in patients that had malignancies and were losing weight or becoming cachectic or wasting away. It was noted that they had high levels of this. That's why originally tumor necrosis factor alpha was called cachexin. Okay, well, since then a beta's been discovered. But the thing you should know about TNF alpha is it's not only made in macrophages, as well as a couple of other cells, but it activates macrophages. So that means it has an autocrine function. And what do activated macrophages do? Well, they chew up other cells, don't they? They are very much involved with apoptosis, and therefore the reason for these cancer patients losing weight is because the macrophages were chewing up other cells under the influence of tumor necrosis factor. That doesn't mean it caused necrosis of the tumor. It means they could cause necrosis in general of other cells in their body, which is why they lost weight. Another thing to remember, and we're going to we have several other areas where you show examples of this. TNF alpha, along with a very, very another important cytokine, interleukin 1. TNF alpha and interleukin 1 are not only one of the most important, we'll call them cytokines or small proteins, or I don't know if we could call interleukin a growth factor, but together TNF alpha and interleukin 1 are the two main regulatory substances in the whole cascade of healing. Okay? Not only do they do things, but they control a wide variety of other growth factors and cytokines to do things as well. So as long as we talked about interleukin 1, you should know that there's a whole bunch of them. They're made in macrophages, like TNF alpha and other cells. They are involved in angiogenesis. Well, that's no surprise, because didn't we say that just about all the growth factors were involved in angiogenesis? Chemotaxis, okay, attractant to cells, chemokines, so to speak. And with TNF alpha, like we told you before in the previous slide, regulation of other cytokines. And there's a big family of interferons, okay? Interferons are classically made by lymphocytes. We also know that fibroblasts can make them. It activates macrophages, but inhibits the fibroblasts. So interferons are very, very important in viral immunity, but there's a bunch of them. It's also has a regulatory role with other cytokines as well. And this we've already mentioned. We don't have to say much about it. The growth factors and other protein regulatory molecules, if they work on the same cell that they are manufactured by, that's called autocrine. Most of them work on physically neighboring cells, okay, the growth factor. So that's called paracrine. So auto means self, para means near. And technically some of them, if they are delivered by blood stream to other areas far away, you could say by definition that's an endocrine function, isn't it? But the main function of the substances we've been talking about for the most part are cells in the nearby damaged and healing neighborhood. So there's autocrine. They make substances. The receptors are on the same cell. There's paracrine. Makes substances and goes to neighboring cell or even adjacent target cells. And if, of course, they don't just go to adjacent cells, but they travel downstream, then that's the endocrine function. One of the ways they work when you get down to the molecular level, this was an example of hepatocyte regeneration. But one of the way that these substances work, you don't have to memorize this chart. I still don't really understand it myself, to tell you the truth. But the thing to remember is that at the molecular level, these growth factors and other substances are involved in transcription. So they could be called transcription factors. Okay, remember, transcription is the conversion of DNA to messenger RNA. Okay, so what these substances do is they control the movement or transcription of genetic information from DNA to mRNA by virtue of acting on the RNA polymerase. And that's as far as I'm going to go from the molecular point of view. Beyond that, to tell you the truth, if it is understood, I just am not smart enough to understand it myself. Okay, we talked about all of the area in which this healing is going on. We call that the extracellular matrix. And those are not cells, but but they're products of cells. Some of them are structural, some of them are adhesive, okay? As you know, the main protein substance between cells, and we're probably more likely in connective tissue rather than epithelial tissue, because in epithelial tissue, the cells are right up against each other, aren't they? But collagen is the main structural protein and the main substance in the extracellular matrix. And you think, well, that's nice. I got news for you. There's like 18 different collagens. And by the time this lecture is over, maybe it'll be 19. I don't know. But when you think of structural proteins that are between the cells, think of collagen. Think of the elastic fibers, okay, of which elastin is an important thing. Fibrillin is another structural protein. Also, remember we talked about the cellular adhesion molecules, this very, very huge family of molecules that basically make cells adhere to each other. We talked about the integrins, the selectins, okay. These are all components of the extracellular matrix. The things that we see like in cartilage and other connective tissue, bone, the proteoglycan. So if you have a protein that is between a cell in an area, most likely it's going to be one of these guys that you see here, and an integral or component of the extracellular matrix. So why is this extracellular matrix so important? Because in the whole process we've been talking about, they are the environment. They're the scaffold, so to speak, in which the house of healing occurs. They are the microenvironment for the healing we've been talking about. They also are the place where the growth factors are stored, okay? So you don't just have a growth factor going directly from one cell to another receptor. We can have storage of them as needed, and that storage occurs between the cells, obviously, in the extracellular matrix. Now, I'm not going to expect you, and I don't think anybody in their right mind would expect you to know all of the 18 different types of collagen and where they come from. But probably when I was a medical student, maybe there were 5 or 6, I don't know. But one thing that is very, very helpful, and I don't know where I got this from, okay, certainly not a textbook, but if you could think of collagen 1 as being the first one that was discovered, and look at collagen 1 has ONE. So that's the main collagen of bone, ONE. So if you put a B before the 1, you know where collagen 1 is the primary collagen of. Collagen 2 requires a little imagination, but if you want to say collagen 2 is in cartilage, that's the main collagen of cartilage. If you want to say collagen 3 is the main collagen of reticulate fibers or reticulin, it's the main collagen of reticulin fibers. And the one I like best is collagen 4. Collagen 4 is on the floor. That means most basement membranes are composed of collagen 4. So that's where the different collagens are. And you can imagine, okay, because every collagen is different chemically, maybe slightly. It is determined by genes ultimately. There could be genetic defects or mutations where there is an inadequate production. And for every one of these collagens where there is a lack of it, you can have a different disease. Now, we says collagen 1 was bone. So the main disease of collagen 1 lack, or imperfect collagen, is called osteogenesis imperfecta. Basically, it's a disease of bone, serious disease technically. And it's also in another disease involving the elasticity of areas like skin called Ehlers-Danlos syndrome. Because we said collagen 2 is cartilage, that the achondrogenesis or problems with collagen cartilage formation would be due to a defect in collagen type 2. Even though Ehlers-Danlos disease or Ehlers-Danlos syndrome is basically a disease of elastic tissue, didn't we say that collagen 3 is reticulin, which are like elastic fibers? They are not as strong as collagen fibers, but they are in more of a loose elastic kind of a tissue. Well, a genetic defect causing a lack or inadequate production or abnormal protein would cause classical vascular Ehlers-Danlos. But there are Ehlers-Danlos variants that you might see, that you also see with absence of collagen 1 and absence or problems with collagen 5. Okay, I'm going to run down these other ones. I don't expect you to know everything about them because I don't. Okay, but there's a syndrome called Stickler syndrome. And in Stickler syndrome is a kind of a funny syndrome. There's some facial abnormalities, hearing and joint problems, myopia. I'm reading the list down here at the bottom. Hyperelasticity. So that would be due to a collagen 9 defect. In a collagen 4 defect, remember we said 4 was the floor, you have problems with basement membranes, and that would involve, of course, the basement membrane of the glomerulus, the glomerular basement membrane, probably the most important membrane of your body. So these people can wind up with renal failure, renal problems because of a genetic lack of collagen 4. Bethlem myopathy, as you might guess, is a myopathy of muscles. It also involves ankles, fingers, and joints as well. Dystrophic epidermolysis bullosa, you might think of as a bullous skin disease, very serious disease, a lot of big blisters, has a certain degree of mortality that is unappealing. Collagen 9, again, besides causing Stickler syndrome, can cause problems with epiphyseals of bones. Collagen 17 is another type of bullous skin disease. And finally, whoops, hold on. Let me turn this off. Finally, Knobloch syndrome, due to defects in collagen 15 and 18, have a lot to do with eye problems. I think that's about all that you need to know for now. But with 18 different types of collagen, and every type of collagen being determined by different gene, these would be some of the syndromes that you heard about. You know, there was a whole family of diseases that they called collagen diseases, okay? And it's really a bad term, because the collagen diseases, like, you know, like lupus and rheumatoid arthritis, they are not diseases of collagen. They're just a disease in which a lot of scar tissue forms. So the word collagen disease for the systemic autoimmune diseases is not really used anymore. But the collagen disorders, not the collagen diseases, but the disorders, are basically genetic diseases in which you would have a whole pretty long list here of various specific diseases and syndromes. So we've been through this already. We know the difference between regeneration and healing. We spent a lot of time on healing. And do you remember in the last webinar, if you were there, we had a big list. Probably you might call this a sequence, okay, or you might call it a saga, or you might call it a list of events that occur in fairly linear order, even though there's a lot of overlap, okay? We talked about the healing sequence. We said it starts following damage or inflammation. The second general thing is the proliferation and migration of connective tissue cells, especially the vascular endothelial connective tissue cells called angiogenesis, the ingrowth of new blood vessels, what you will be seeing in your patients as granulation tissue, followed by the deposition of fibroblasts, creating collagen, okay, and other proteins in the extracellular matrix. Because of that new healing process, there's remodeling of tissue. It may be minimal if the ECM was not damaged much, or it may be big. But whatever that fibrosis is, will eventually strengthen. So fibrosis is not just scar tissue. It's scar tissue and then followed later on by wound contraction, or the collagen or the scar or the fibrous tissue getting stronger. And that's basically the more or less last phase if there is healing. Now, do you remember when we talked about inflammation, the inflammation sequence or the inflammation epic or the inflammation list of linear events? We said there was a vascular phase. We said there was a cellular phase of neutrophils. And then we said there were a whole wide bunch of mediators. Well, if you want to think of healing in terms of three also, you can say that healing starts out with the disappearance of the neutrophils, followed perhaps several days in general of ingrowth of endothelial cells or new blood vessels, or what we call granulation tissues, and finally a scar, fibrous tissue, collagen deposition. And then that is strengthened as well. So once again, if you could remember only one PowerPoint in this whole presentation in terms of the sequence events of what's going on, without getting into the fancy biochemistry and crap like that, this would be like probably my favorite slide. We also said that the key component of this process is the ingrowth of new blood vessels. We gave it various names. It is derived from endothelial precursor, perhaps stem-like cells under the influence of a whole wide variety of growth factors. It could start from the pre-existing vessels as well. It's stimulated / regulated by growth factors. And here are probably the two main ones. But if you remember, we probably listed about 4 or 5 others. It's also regulated by various other proteins in the extracellular matrix. And look, here's all the different names for it. And this is probably one of the main events that goes on in healing or angiogenesis: granulation, organization, neovascularization. Some people call it organizing inflammation. Okay, well, that's not a bad name either, because it follows inflammation. Here's some nice pictures. See all those red guys there within the tissue? Those are blood vessels. That's granulation tissue. The reason why there's so many of those little red blotches is because there is an ingrowth of the little ones and the medium-sized ones. And look, following the vascular granulation, neovascularization phase, you now have a histologic picture in which, yeah, there's still some of these little clefts or blood vessels. You can see blood cells in them. But the main picture is green. And why is it green? Because there's a common stain that's used to measure the degree of fibrosis, which is called a trichrome stain. And the trichrome stain, or Masson's trichrome stain, used in pathology all the time, stains collagen fibers blue. So we go from red to blue. And let's see, we probably have a few other things we want to show you. Yeah, this is pretty much the same thing. This is your sequence of events. There's the inflammation, there's the vascular proliferation, and there's the maturation. But remember, these are not separate events. There's a lot of overlapping. So the vascularization, the granulation tissue, can start even before the inflammation, neutrophils, is over, and the fibrosis can start, the collagen deposition can start in the middle of the vascular granulation phase as well. One of the things that is very popular in clinical medicine and the concept of intention. There's healing by first intention and there's healing by second intention. First intention, probably the best example, is a clean surgical incision. It's sterile, it separates tissue, but the tissue can be put back with nice, smooth, even edges, okay? And you would guess, because there's not much extracellular matrix damaged, that would probably have not much scarring at all, okay? But in second intention is generally not associated with clean surgical procedures. These are associated with tissue trauma, you know, a piece of glass coming through the skin in a car accident or something like that, in which there's a lot of disruption and therefore a lot of granulation and a lot of fibrosis. So the more traumatic the tissue injury, generally, the more scarring there is. So there's wound healing as defined by first intention wound healing. The edges are lined up. And in second intention, the edges are not lined up. Therefore, there's more granulation and more fibrosis. And remember, I told you that these three phases are not separate, but they overlap. Look, the granulation starts well into during the inflammatory phase. The fibrosis starts maybe about 2/3 of the way into the granulation phase. And of course, if you want to talk about wound contraction or collagen remodeling, strengthening the scar, you could probably add that as a fourth thing as well. When you go and visit your patients after surgery, okay, you may see something like this. And you say, well, look, it's kind of yellow. There's a lot of red around it. Maybe those are new blood vessels. But look, there's a lot of yellow. Maybe that's still like a lot of neutrophils too. This is granulation tissue. The thing I want to warn you about is that if you don't have a lot of experience, you could look at healthy granulation tissue and probably think it's infected, okay? So remember, all of those blood vessels does not mean infection. All of those blood vessels, which you can see here microscopically as well as grossly, are the result of the granulation tissue or neovascularization, the action of growth factors on endothelial cell precursors to make them endothelial cells, new blood vessels. Fibrosis. How long after an injury does fibrosis occur? Well, it's not quick. It's not days. We'll just say it's in the weeks to months thing, but the longer it's there, the stronger it gets, okay? So if you have scar tissue, it may very easily last, forever. And it may not occur within a couple of days, but it may start to occur within a couple of weeks or months, can persist into years as well. And I think there's a saying about that scar tissue is basically stronger or has more tensile strength than the tissue from which it arose from. And that's generally true because there's probably a few things that really have more strength than a contracted scar. And here's the last two tissues. Getting a little bit into the clinical business now. What might retard or interfere with this beautiful saga or process or sequence of healing that we just spent an hour and a half talking about? Well, obviously, the less blood supply there is to that organ, the more complicated or retarding or longer it's going to take. Nerves have also an important effect as well. the less a tissue is innervated, the less and longer it's going to take to heal. Okay, local infection. Obviously, if it's infected with secondary bacteria, maybe it wasn't debrided properly, or maybe it was just an overwhelming amount, then that would be another factor. These are all pretty logical factors, I think. Foreign bodies, if there is a piece of glass, a piece of sand, a rock, a piece of vegetable matter, obviously, and it's not cleaned up, or maybe nobody even tries to clean it up, that's going to be a retarding factor or interfering with proper normal healing. Presence of a hematoma, okay, a pool of blood, perhaps even a hematoma that's starting to organize too. So look at, now we have even blood clots that can trigger off granulation tissue. That hematoma can act theoretically as a retarding factor. It can also produce stress or pressure on the tissue and interfere with the blood supply. These are all logical things. And of course, the more tissue that is necrotic, the longer it's going to take to clear it up, the longer it's going to take to heal. And by clear it up, I don't mean surgically clear it up. I mean the tissues themselves, the neutrophils, the phagocytes, cleaning it up. So these are all the local factors that would involve in delayed wound healing. Here are some of the systemic factors. Well, we all know that old people don't heal as quick as young people. We all know that if they have a heart problem and they have decreased blood supply, again, just like with the local factors, they're not going to heal as quickly. We know if patients are anemic and they might have enough flow, but they don't have enough hemoglobin, that's going to be a factor. People that have malignancies of any type or any location, or the more advanced the malignancy, the longer it's going to take for a localized wound to heal. People that have not had enough or proper nutrition, obese people, fat people don't heal as quickly as thin people, okay? People that have infections elsewhere. If you have a leg ulcer or a leg damage or a leg inflammation, but the patient also has a pneumonia, well, that's going to delay the leg local healing as well. Any significant organ failure, kidney, liver, lung, heart, in general, doctors will tell you these patients just don't heal quickly. And guess what? We're done. So, I wanted to play a song at the beginning, but I didn't have enough bandwidth because I wanted to play it using the same bandwidth. And it's basically dedicated to my friend Woofy, who was with me for about 10 years, or at least 8 years of webinars, and now he's no longer with us. So I'm going to play a little final closing song, kind of an inspirational song, and I won't be using the bandwidth of the webinar. I also put it on my phone, so you might hear it, and I'm hoping that I could project it onto the screen as well. So I guess at this point we'll just say thanks for coming. We didn't have to go the entire 2 hours, which I was fearing we might. I feel we had a pretty good webinar today. The movie will be ready probably in an hour or two after I start, crunching it and uploading it. And let's sign off with my, without a doubt, favorite song by that phenomenal rock group called ABBA. It's one of their new songs. And I'm going to play a little Woofy video with that new song that was made by one of my favorite medical students of all time, Sarah 8. So let's see if it works. It might not be a good quality sound as before, but I think you'll be able to see a nice video as well as hear the music. So cross your fingers. I'll go into my little directory here, and let's do our final tribute to Woofy.
I still have faith in you. I see it now. Through all these years that faith lives on. Somehow there was a union of heart and mind, the likes of which are rare and oh so hard to find. Do I have it in me? I believe it is in there. For I know I hear a bittersweet song in the memories we share. I still have faith in you, and I will say I never really thought I'd feel this way, but I remind myself of who we are, how inconceivable it is to reach this far. Do I have it in me? I believe it is in there. For I know I hear a bittersweet song in the memories we share. We do have enough. Your spirit has arrived. The joy and the sorrow. We have a story that is alive. And we need one another. Like fire is in the wind. Do I have it in me? I believe it is in there.
Well, if I seem like I'm a little choked up now, I think you'll understand why. But it still won't stop us from doing what we always do, and we say, rock on, buzzards.